Question 101. A patient has been newly diagnosed with hypertension and is taking multiple medications, but their blood pressure remains uncontrolled. The patient has been identified as having secondary hypertension. During the examination, a bruise is detected near the umbilicus. What is the most probable cause of this secondary hypertension among the following options? Option A, Cushing syndrome. Option B, Addison disease. Option C, Conn syndrome. Option D, renal artery stenosis. The correct answer is option D, renal artery stenosis. Here's an explanation. The patient's blood pressure remains uncontrolled despite being on multiple medications. This resistance to treatment raises suspicion of secondary hypertension, which is often caused by an underlying medical condition. The detection of a bruise near the umbilicus during examination is highly suggestive of renal artery stenosis. This condition can result from various causes, including atherosclerosis and fibromuscular dysplasia. Reduced blood flow to the kidneys can trigger the renin-angiotensin-aldosterone system, leading to increased blood pressure. Option A and option B are associated with hormonal imbalances but are less likely to cause hypertension with the specific findings described in the scenario. Option C could potentially cause hypertension but is less likely to be associated with a bruise near the umbilicus. Question 102. A 69-year-old male with ischemic heart disease who is currently taking lisinopril and bisoprolol, has a potassium level of 10. What should be the next course of action among the following options? Option A, administer IV calcium gluconate and perform an ECG. Option B, administer IV insulin and dextrose. Option C, administer sodium bicarbonate. Option D, administer IV Lasix. The next course of action in this scenario should be A, administer IV calcium gluconate and perform an ECG. Here's an explanation. A potassium level of 10 is extremely elevated and requires immediate attention. Hyperkalemia can have serious cardiac effects, potentially leading to life-threatening arrhythmias, including ventricular fibrillation. Administering IV calcium gluconate helps stabilize the cardiac membrane and counteracts the cardiac effects of hyperkalemia. It does not lower potassium levels but temporarily protects the heart from the adverse effects of high potassium levels. Performing an ECG is essential to assess the cardiac effects of hyperkalemia. It can reveal changes such as peak T waves, widened QRS complexes, or other arrhythmias that may require immediate intervention. IV insulin and dextrose can be used to temporarily shift potassium from the extracellular to intracellular space but is typically reserved for slightly elevated potassium levels. In this case, with a potassium level as high as 10, immediate action with IV calcium gluconate is needed. Sodium bicarbonate can also be used in the treatment of hyperkalemia to shift potassium into cells, but it is not the first-line treatment when cardiac effects are severe. IV Lasix is not the appropriate initial treatment for hyperkalemia, as it focuses on potassium excretion rather than addressing the acute cardiac consequences of hyperkalemia. Question 103. A 58-year-old male with a known history of dilated cardiomyopathy and currently taking medications has come to the hospital with symptoms of confusion. Upon examination, he appears to be in a euvolemic state. His sodium level is measured at 124 millimoles per liter, and both serum and urine osmolality have been assessed. Urine osmolality is greater than 300 milliosmoles. What is the most probable diagnosis among the following options? Option A, syndrome of inappropriate antidiuretic hormone secretion, SIADH. Option B, diabetes insipidus. Option C, hyponatremia with expanded blood volume. Option D, hyponatremia with reduced blood volume. The most likely diagnosis is syndrome of inappropriate antidiuretic hormone secretion, SIADH. Here's an explanation. The patient has confusion, which is a neurological symptom, and is euvolemic upon examination, meaning there are no apparent signs of fluid overload or dehydration. The serum sodium level is low, 124 millimoles per liter, indicating hyponatremia. The serum osmolality is low, which is consistent with a dilutional hyponatremia. Additionally, the urine osmolality is greater than 300, indicating that the kidneys are concentrating urine appropriately. In SIADH, the kidneys retain water, leading to concentrated urine despite hyponatremia. Option B, diabetes insipidus is characterized by excessive thirst and large volumes of dilute urine due to insufficient production or action of ADH. This condition would typically result in hypernatremia rather than hyponatremia. Options C and D do not fit the patient's presentation, as they would typically involve signs of fluid overload or dehydration, which are not observed in this case. Question 104. A patient with a known case of cancer and metastasis, who has undergone chemotherapy, has come to your clinic for a follow-up appointment. The patient is drowsy but stable with room air and has a sodium level of 111 millimoles per liter. How would you approach the management of this patient among the following options? Option A, administer intravenous normal saline. Option B, restrict water intake. Option C, increase water intake. Option D, administer dextrose 5% in water. The correct answer is option A, administer intravenous normal saline. Here's an explanation. A sodium level of 111 millimoles per liter indicates severe hyponatremia, which can lead to neurological symptoms such as drowsiness, confusion, and potentially seizures or coma. The patient is described as vitally stable on room air, indicating that their blood pressure, heart rate, and oxygen saturation are within normal ranges. This suggests that the primary concern is severe hyponatremia rather than immediate respiratory or circulatory distress. In cases of severe hyponatremia, the primary goal is to raise the serum sodium levels gradually while closely monitoring the patient's neurological status. Intravenous normal saline is the initial treatment of choice for hyponatremia. It helps restore sodium levels by providing a source of sodium without additional water. The rate of correction should be controlled to avoid overcorrection, which can lead to complications such as central pontine myelinolysis. Option B and option C are not appropriate in this scenario. Dextrose water is not the first-line treatment for hyponatremia, as it is a hypotonic solution that contains no sodium and can further dilute serum sodium levels, potentially worsening the hyponatremia. Question 105. A 30-year-old homeless male who consumes alcohol and has hepatomegaly arrives with abdominal pain. Laboratory results reveal high anion gap metabolic acidosis, and urine microscopy shows the presence of calcium oxalate crystals. What is the most probable substance involved among the following options? Option A, salicylate poisoning. Option B, ethanol toxicity. Option C, methanol toxicity. Option D, ethylene glycol toxicity. The most likely substance involved is ethylene glycol toxicity. Here's an explanation. Ethylene glycol is metabolized in the body to toxic metabolites, including oxalic acid. The accumulation of oxalic acid leads to metabolic acidosis with a high anion gap. Ethylene glycol toxicity can result in the formation of calcium oxalate crystals in the urine, which can be observed on urine microscopy. These crystals are characteristic of ethylene glycol poisoning. Salicylate poisoning can also cause high anion gap metabolic acidosis, but it typically does not result in the formation of calcium oxalate crystals in the urine. Ethanol is not a strong acid, it does not typically result in significant acid-base disturbances. Methanol toxicity can cause high anion gap metabolic acidosis, similar to ethylene glycol toxicity, but it is more commonly associated with visual disturbances and other neurological symptoms.